Martha is 93. She has a number of long-term conditions, lives at home, and is supported by a care package and her family. She uses a Zimmer frame at home to move about. Unfortunately, last night she tripped and fell on her way to the toilet and was unable to get back up. She pressed her pendant alarm and an ambulance brought her to our emergency department. She arrived at 5 in the morning and was admitted to our clinical decisions unit for assessment by the Old Persons Assessment and Liaison team this morning.
My name's Dr. Sally Briggs. I'm a consultant geriatrician at Wythenshawe Hospital, which is part of Manchester University NHS Foundation Trust. I work as part of the OPAL team, which stands for Older People's Assessment and Liaison, and we work clinically in our emergency department, in our clinical decisions unit and on our acute medical unit, assessing, reviewing and looking after frail older people who present acutely to our hospital. Comprehensive Geriatric Assessment, or CGA, is a multidimensional and usually interdisciplinary diagnostic process. The purpose of it is to assess and carry out a holistic plan for treatment, rehabilitation, support and long-term follow-up. It's very patient-centred. It's about identifying a patient's priorities and how we can try and enable those to be carried out in practice. So therefore it's designed to determine a frail older person's medical condition, including their mental health, functional capacity and also their social and wider circumstances. If we accept that there are times when it is very important to avoid hospitalisation, it is useful to remember there are a number of factors that help you to avoid admitting patients to hospital inappropriately when they're frail. These are early recognition that a patient has frailty so that you can assess them in a different manner and you can wrap the multidisciplinary team around them. A multidisciplinary team consists of a number of different healthcare professionals, usually doctors, nurses, therapy staff, either occupational therapy or physiotherapy, social care colleagues, plus maybe pharmacy, dietetics and the voluntary sector, depending on an individual person's needs. It's really important that we work together because we all have different skills and strengths that will benefit the patient in different ways. Earlier senior review is key. We know that a senior decision making is far more likely to decide to admit rather than admit to decide. You need early comprehensive geriatric assessment because this is the best chance you have of enabling a patient to return home in a timely manner and stay at home, avoiding early readmission. It's important to assertively manage acute on chronic conditions. So if the patient has delirium because they have a lower respiratory tract infection, clearly it's important to treat that and manage that as well as wrapping the rest of the plan around them. And as soon as that acute condition has stabilised or resolved, it's important to get the patient home as soon as possible because we know that patients do better in their own environment. Not all hospitals have an acute frailty unit and it's not the be-all and end-all of everything. What's important is that frail older people are identified when they present acutely, so there's a different offer for them. It's about the staff, the team that you work within, having the appropriate competencies and skills to manage patients in the way we've described.
I'm Alison Walsh, I'm an occupational therapist within the OPAL service. As therapists, we look at a person holistically and we complete the therapy component of the complex geriatric assessment. We work alongside a person, their carers and their social support systems, both formally and informally, our colleagues internally and externally. We look at them both physically, emotionally and socially to understand how they're going to cope at home, and from that then we tailor a package to support them leaving hospital. Clients who experience more frail conditions can be prone to deteriorate quickly if we do look at admitting them. In that point of view, both to enable the person to have the best physical and quality of life components, we need to look at ensuring that we can discharge them with support quickly, avoid deconditioning and promote well-being within the community.
So Martha will be assessed this morning. I will see her from a medical perspective, do her medication review. The therapist will see and work with her and will establish what her goals are about hopefully returning home. Once we've identified and treated her acute medical problems, the idea will be to get her home later this afternoon with a plan to help support her at home. Sometimes this involves help from services in the voluntary sector, but it may be a simple restarting of her current package of care.